Right, it's 2 o'clock, so I am going to start and to welcome you all to the online summit on migrant health dermatology. And if I could ask my co-host to mute everybody, that would be great. And I'd just like to welcome you all and hope that we have a wonderfully successful meeting. And I'd like to thank the ILDS Secretariat team and also David Felker, who is supporting us from Indiana with the Zoom technology. So on the chat function, you'll see that the instructions for how to engage with the meeting are there, and the team will pop them in every now and then just to remind you. So next slide, please, Claire. That's the tips which we've just got there, so on to the next one. And halfway through the meeting, well, actually after the first 3 talks, we'll then have a photo which is will be screenshots of us, so that gives you a chance to have your video on, and we'll warn you when we're doing it, but we'll take a picture of the conference participants. Next slide, please. And what we'd like you to encourage you to do during the meeting is to put your questions and thoughts and comments in the chat function so that we can pick those up as we go along. At the end of each talk, we will have an opportunity for questions, but we hope most of those will have appeared in chat to give the chair a chance to bring out themes to discuss in the 5-minute discussion session. But you do have an option to put your hand up. There is a little hand up function on the participant area. So next slide. So the aims of the meeting today are to include the issue of our pandemic that we're experiencing at the moment within our talks around considering migrant health dermatology, and to see what opportunities we have to act now and immediately to support migrant health dermatology, and also to consider contributing to this special edition of the Tropical Medicine and Infectious Disease Journal, which will give us a mouthpiece and an opportunity to develop our platform and messages. Next slide, please. So just for those of you who are attending who are not dermatologists, the ILDS, the International League of Dermatological Societies, is an NGO that promotes improvement of dermatological care, education and science across the world. It now has it now has 195 member societies from more than 90 countries, representing more than 200,000 dermatology specialists across the world. Next slide. And the International Foundation for Dermatology is the part of the ILDS that focuses on skin health services in areas of low resource, ensuring they're available, accessible and effective for all patients, regardless of their ethnicity, disability or social background. So the Migrant Health Working Group is one part of the activities of the IFD. And I was just looking back at the history of this, and we started to talk about it, I think, Toby, back in 2017, probably over a glass of something delicious. And have been having some teleconferences during 2018-19. We've developed a membership which is growing, but also very keen to involve and work with partnerships and appropriate stakeholders and increase the community where we need to. So we're very pleased to have members of WHO with us, MSF, and we're really looking forward to that engagement. So the membership so far has fieldwork experience and expertise in a range of appropriate areas, such as displaced people's camps and reception centres. And we are at the moment thinking about that our priorities and direction are around the development of teaching materials and support for healthcare workers in camps, but also aware that we are potentially important in advocating for skin health among migrants in general. Next slide. So this is the current Migrant Health Working Group membership of the dermatology component. If I've missed anyone off, I'm really sorry. Next slide, please. And what we want to aim to do today, well, just to mention that we are recording the meeting and we've also shared with you the presentations. We will be planning on having this as a resource that we could actually widely share subsequently to people who are interested. We want to start thinking about our opportunity to produce a special edition of the Tropical Medicine and Infectious Disease Journal. And so during the meeting today, if you have if you are keen on being involved, do get in touch with me as a contributor or supporting if you're willing to put your hand up to support with guest editors, we can work out our team for producing this. And any ideas that you have that we could have for articles for this special edition, do pop them into the chat function. So we also want to, I also thought it would be useful at the end of this meeting to collate accepted, submitted or soon to be submitted articles of relevance around migrant health dermatology. So if any of you have produced any, published any, and are happy to just pop those in the chat function too, we can just make sure we're picking them up as we go along. I want us all to think about a shared platform, whether this is a teledermatological platform, I think is one issue, but also a shared platform where we might collect our ideas. And obviously some of us have been working with Dropbox so far. Is that the most relevant platform? Should we think about something else? And also to think about other virtual health opportunities. So at the end of this meeting, or the last section, Toby's going to facilitate a discussion around virtual health opportunities for dermatology. So if you have any thoughts about what you'd like to include in that discussion, again, if you could pop those in the chat function as we go along, if anything occurs to you. So I'm just noticing a question that's come from Ishmael. How do you become a member of the IFD? Well, the International Foundation for Dermatology is like a committee of the International League of Dermatological Societies. So it's not really, if you're a member of a member society of the ILDS, you are actually also effectively part of the IFD. So that's how you become a member. But it's also probably worth thinking about joining GLODERM if you want to keep up to speed with global health dermatology issues. So I'm going to stop there because that's 7 minutes and it's gone over. I've already gone over, my goodness. On to the next slide, please. On to the next one, thank you. So I'd like to hand over now to Valeska, who is going to chair the next session, a series of 3 talks.
Let me unmute, okay. Hi to everyone, and thank you for coming today to this e-conference. And I'm very sorry that we don't meet in person, and I really hope that we can meet soon here in Malta. So I'm going quickly to introduce next speaker. The first speaker of the session today is Joseph Bartovic. Joseph is a technical officer with the Migration Health Program at the WHO Regional Office for Europe. He worked previously for the Regional Commission for Western Asia of the United Nations in Beirut, Lebanon, where he was covering migration issues in the Arab region. And after completing his study in politics, he lived in United Kingdom, working at the Ministry for Health and the Public Health England and the National Health Service. Now he's collaborating with the WHO. He works primarily on evidence generation dissemination, including the European Commission funded MICA project and the Knowledge Hub on Health and Migration. And we are going to hear his talk about WHO response to the international migration and refugee crisis. Every speaker will give a brief overview, I think, about the COVID situation in Europe and in their country, I think. So welcome to the meeting. Joseph?
Thank you very much. Hello, good afternoon.
Good afternoon.
It's a pleasure to be part of this meeting, and thank you for inviting us and for also drawing attention to what is a very important issue. So in my presentation, if I could have the first slide, please, I will cover 3 areas. First of all, I will talk about the WHO Migration and Health Program. Then I will talk about some of the overlaps between the public health aspects of migration and dermatology, and also sort of see what are the potential areas where we could collaborate or work together or come together in the future as well. And also finally, I will give a brief update on our COVID response, focusing on refugees and migrants. So first, I will start, and we can move on to the next slide, thank you, talking about the work of the WHO Regional Office for Europe on refugee and migrant health. This work has started back in 2011, and it was actually founded by Dr. Santino Severoni, and I'm actually standing in his place today. He founded the migration and health work at WHO, and this has since then developed into a large body of work and a programmatic body of work, and I can summarize this around 4 pillars. So the first pillar, first area of our work is strategy and policy development. And in the WHO European region, we have the European Strategy and Action Plan on refugee migrant health, which was adopted in 2016. And since then, we have been working very hard to promulgate the strategy and to implement some of the commitments. So 53 member states of our region have made commitments towards refugee and migrant health. We are helping them and supporting them to implement this, and we're also monitoring the progress, and we have done this in 2018, so 2 years since the adoption of the strategy. We have done our first survey and a report on progress, and then we're doing the same again this year, reporting back on the progress of the strategy. The second area of work is technical cooperation and country support, and we work with countries based on their specific needs. So we respond to country requests and we work with them on, be it, for example, contingency plans, national policies. We conduct assessments to look at health system capacity to respond to large arrivals of refugees and migrants. But we also have members of our team, national professional officers working in countries which have large numbers of refugees and migrants. For example, we have a migration specialist in Turkey, in Greece, in Serbia, and so on. So that's a big part of our work. And then another area is evidence and knowledge. There has been a body of evidence on refugee and migrant health for a while, but this has been often fragmented. It has not been presented or put forward systematically. And what we have done in the program is that we have tried to consolidate a lot of the evidence. We have also tried to address some of the gaps in evidence, and we're doing this through a number of knowledge products that we have, be it the European Refugee Migrant Health Status Report, but also evidence series on focusing on the latest evidence in refugee migrant health, but also we have another series of technical guidance documents focusing on policy recommendations, considerations, strategies, and interventions for policymakers. So that's a big part of our work. And finally, communications and advocacy. We've been trying to bust some of the myths around refugees and their health status, around misconceptions around the health status, but also raise awareness and disseminate some of the knowledge products and information that we have produced under the evidence and knowledge pillar. We have a number of tools for this. We have a series of webinars that we do. We have the summer school on refugee migrant health and so on. So those are all under the Knowledge Hub on Health and Migration, and providing information on the last slide in terms of resources that you can access if you would like to find out more about these. In terms of
sorry to interrupt you, but we're just going to have to move you on quite quickly if we can. Thank you.
No worries. So in terms of the overlaps, I just want to say one thing. There is a lot in terms of skin health and refugee migrant health. The first time I was in Sicily in our summer school, we had a speaker from Lampedusa who was actually, as part of his presentation, showing photos of some of the most common injuries and conditions that refugees arriving through the Mediterranean have. And these were actually chemical burns from the leaked petrol and leaked petrol mixed with seawater. And it is not just burns from these chemicals, but also as a result of torture and violence. We have also in our report some information about the most common skin conditions, for example, scabies. We have also some information about the most at-risk groups, such as children, and who are particularly at risk of infections. Some of the poor living conditions, which are also associated with skin health. And finally, an area of interest for us is also health checks and initial health status assessments. And there are some countries which have actually included dermatologists in the in carrying out these assessments. So it is a lot that we could be carrying together, covering together, a lot of areas, and we have covered some of it in our technical guidances and our knowledge product, but there is definitely more that we could be doing, and it would be interesting to look at the collaboration going forward. And finally, on the last slide, I would just like to, I'm providing a summary, or the penultimate slide, summary of our response to COVID, in terms of both gathering information and data of what's happening with COVID, but also policy changes, and producing guidance both for Europe, global, camp setting, non-camp setting, and so on. So I invite you all to look at these. And if you have any more questions, there are my details also in the presentation. So happy to answer any questions.
Hi, Joseph. Thank you very much for your presentation. We are open to a few questions, I think, if any one of the audience has questions. At the moment, in the chat, there are no questions. I have a question for you. I also work in Lampedusa, and I'm still working in Malta, collaborating with public health, also in the skin health assessment of migrants on arrival. And I will give a brief overview of my experience, which is the same in Lampedusa and Malta.
Yes.
But there is a lack of guidelines about this. I didn't understand what you say. Are you publishing some guideline about the skin disease screening at arrival, or not, as WHO?
So in Italy, there is the Italian National Guideline for Border Checks, which I think has been designed by the Iom Pre, the National Institute of Migration and Poverty. And it is, and I'm not 100% familiar with it because most of it is in Italian, and I don't speak Italian. I have seen an abridged version in English, and I don't know into what extent they cover dermatology. But I know that, like you say, dermatologists are part of the multidisciplinary teams. There is people from internal medicines, infection diseases, dermatologists, pediatricians, nurses, and I think transcultural mediators as well, who are part of this. Now, this is this Italian guideline on border checks and or health checks at borders is definitely a good way forward, but not all countries are actually. I'm only aware of a few that have this sort of resource, and I think we need to really look at how we can best calibrate this sort of health checks. And we've been actually wanting to start a project with Iom Pre to look at developing a European guideline or advisory document on these health checks, and how to calibrate them. And of course, we need to look at how we can integrate skin health and dermatological disorders into this. So this is definitely one area where it would be nice potentially to collaborate.
Can I be really bossy now and actually ask us to move on, because we're just running over time? That would be great.
Great, thank you very much.
So thank you very much for your interesting presentation. It's time to introduce Dominic. So I will be very synthetic in your introduction, so we save time. Dominic is a senior migration health advisor at the IOM regional office in Brussels, responsible for development, coordination, and supervision of migration health program activities. Thank you very much, Dominic, for joining us today, and with your presentation titled Screening for TB, HIV, STIs, and other infectious diseases, including COVID-19 migrating population. Thank you.
Thank you, Valeska, for the very nice introduction, and thank you to the organizers for inviting me. I have a very complex topic which centers around infectious diseases and borders mainly. My outline is here, which is basically I'm going to give you a little bit of a background on ID interventions, including screening, borders as an opportunity as well to do something, and particularly hone in on health assessment operations, something that IOM, the International Organization for Migration, the UN Migration Organization, has done since 1951, and where we are doing it and how we're doing it and what we can learn from the screening of TB, HIV, and STIs about and how we can apply that or not to COVID. Next slide, please. This is as an example from tuberculosis. You can see that there are different options. You can screen pre-arrival, that's many of the programs that we do, but you can screen on the border, or you can screen after the border, and you can screen for different stages of the disease. So for latent TB or for active TB in this case. But one thing I don't want us to forget is that there are overarching opportunities such as early detection and treatment, social protection and awareness, and in the case of TB, vaccination. Why am I saying that? Because this will become important for COVID also, because these are the opportunities that you can lay the ground for in at the borders. Next slide, please. So we know that basically of 200 countries in the world or thereabouts, about 200 borders are currently closed. So there will be a drive to reopen, but not without something in place. So this is why this is an important topic. Next slide, please. Borders are also opportunities because at the border, you've got a way of implementing health interventions, as you can see in this matrix from our displacement tracking matrix where they're mapping it out. And you can actually refer, if you do it well, people to health services. Next slide, please. So what is in a health assessment? What am I talking about? Well, if you focus on the left lower box, you can see that it can mean a lot of things. At the moment, for example, the Iom Pre Entry Assessment, this is driven by the member state. It can contain general assessment, medical history, physical examination, and it can test. We can test for specific conditions such as HIV, syphilis, sexual transmitted diseases, tuberculosis I mentioned, etc., etc. It can also provide an opportunity for vaccination, for example. Keep that in mind. Usually, it starts from a very simple to a more complex. So I've got the TB screening thing here. Start, process, result, and you can see that. You will have the slide, so I can go at a reasonable speed. Next slide, please. So, no, the one before, thanks. Yes, so in IOM, in many countries, we are screening for immigrants and immigrants and migrants, immigrants and refugees. And you can see that this is several 100,000 each single year. So we have a lot of experience. Next slide, please, which helped us to build up some capacity. When I say us, I'm talking about IOM, but of course, being mindful that there are many different providers also around the globe that might have similar capacity. So we've got laboratories, we've got opportunities for vaccination, we've got staff, we've got X-ray facilities. Next slide, please. Can we use this existing infrastructure? Well, we have a collaboration with the border forces, we have a worldwide program, we have readily equipped clinics, we have personnel with screening expertise, which is particular expertise. We've got X-ray facilities and laboratory facilities. And a few years back, we published an article looking at how we can, with that capacity, help member states with capacity where it's less there. For example, laboratory for Africa and those kind of things. So I just give you that as an indication for reading. On the bottom right-hand side, you can see what we call an expert machine. Kefit produced these. There are other machines from Abbott and all sorts of things. These are almost bedside tests. They are rapid diagnostic tests, molecular tests with a cartridge. The reason, this is the cartridge for tuberculosis. The reason I'm mentioning it here is that you might be all aware that the FDA has approved not only, by the way, the Cepheid, but also several others, including Abbott, cartridges. And These machines exist around the globe. We should make use of it. Next slide, please. Next, okay, and the next one. Sorry, I skip over that. You can have that in a minute. If you look at the right-hand side, the question is, how effective are screening programs to prevent case importation? And the answer to that is, it's half full or half empty, however you look at it. If you look at the cohort study that we published in the Lancet a few years back on the right-hand side, you can see this is time since migration. If you look at the first year, you will see that there are 3 colors. There is a color blue, which is the incident cases that arose after the screening. The color red, which is the pre-entry prevalent cases that we did find on the screening. And the green cases, the post-entry missed prevalent cases, these are cases that we just missed. Meaning, the take-home message is that screening is not 100% because of the incubation time, because of the test properties, because of many, many reasons. You will only find perhaps up to 50% in any disease that you're screening. So does that make it irrelevant? That's the big question. On the left-hand side, simply that's just the UK program. You can look at it yourself. It's a similar type of message. Next slide, please. So if you look at the pyramid of reporting, we're all aware of that not all infected cases have symptoms, not all that have symptoms go to the doctor, not all that have going to the doctor get a test, and not all positive tests are resulted, meaning that basically you are missing, even in a normal setting, a lot of cases. The classic setup of a quarantine booth, which goes by symptoms and fever, then followed by isolation referral to definite care, maybe with bedside testing, does have several complicating factors. That is the length of incubation and potential transmission during that. Clinical features are highly variable, and many are mild. There's probably a high rate of asymptomatics and effective transmission from these asymptomatics, and there may even be post-disease transmission, all of which will limit COVID screening at borders. The state of the literature is dismal at the moment, as you can expect, but there is some WHO guidance now coming out or has been published on ill travelers at port of entry, which there is a link here. Next slide, please. So what does it all mean? Here is a modeling study, one of the few good studies that have been published, which shows that the effectiveness of screening at border or around border depends on the incubation, the number of asymptomatics, the awareness, and the screening properties, screening test properties, but the detection is realistic only in less than half of the infected travelers. So port of entry screening is not a panacea. Usefulness will depend on the effective referral, early testing, and awareness. It's an imperfect system, but here it is. It's a bit like the glass of water that I put there. It's half empty, half full. So it has, you can say you're missing a lot of cases. You can also say you're finding a lot of cases. So if you're linking them properly into care, it could be an opportunity. Next slide, which was my last slide. You'll be pleased to know. So reopening of borders, I'm very sure, will include some form of COVID assessment at borders somewhere. All border-related screening, and I went through that in detail, has inbuilt limitations, and I list them there again. There is a vast infrastructure, there's also a vast experience, not only with IOM, but many other organizations as well. And there's a potential for upgrading tools that are already there, like the expert machines. But the finding and missing in border screening will find and miss up to 50% of the cases. So the question is one of objective, and it can only be supplementary to other measures. But the utility will depend on defining these objectives. So it's case reduction, it's not avoidance. It's a key will be to have a good referrals pathway and to integrate the borders with national healthcare services. And it could be really useful in that scenario. Next slide. And I shall thank you very, very much for your attention. And that's it. I'm open for questions. Thank you.
Thank you very much, Dominic. We have a few questions here, and we have to go faster through the question because we are a bit late. So there is...
Sorry, I'm going to just butt in. I'm just going to butt in. I'm not sure we have got time for questions. I wonder if we could bring them, perhaps we could do them when we've gone through and heard from Apostle follow us and then see whether we've got time then. Would that be all right? I just don't want us to sort of be encroaching on the next session.
Okay, so we keep on going at this point. Okay, I would like to introduce Apostolos Beit. Apostolos is the Director of Medical Operational Support Unit of MSF Greece, and is very well known. I read one of your recent publications in The Lancet, very interesting about COVID. Please give us an update, and we talk about emergency response to the refugee crisis, including reflection on COVID-19. Thank you very much for joining us today.
First of all, thank you for inviting us in this excellent meeting. I think the previous two colleagues that I know them a long time ago, they did cover certain areas. I will try to address three issues. So there's no slides from my side because for 5 minutes, I mean, there was no time for putting slides on that. But I would like to touch three issues. What does it mean having a chronic emergency? Secondly, how do we see the implementation of so-called guideline and processes and procedures? And of course, what could be the link and what could be the support from the different institutions, including your institution, especially being an NGO also from your side. So in the situation of being to you the emergency responding to the so-called refugee crisis in Greece, I'll try to bring that picture because the picture of refugees around the world is different. But in Europe, this is an ongoing chronic emergency. We are present in the Greek islands at the moment where more than 38,000 people are living in a place for 6,095 people. So that means overcrowding, and you have tents that there are less than 3 square meters when you have 6 to 7 people. There is one toilet for 210 people. There is one shower for 630 people. And there is one water point for 1,300 people. So in reality, if you want to talk about definition of health of WHO or even definition of public health of WHO, this definition, they don't have a place for the Greek islands and for the refugees in Greece. So the people at the moment, they are suffering both on the physical health and mental health purely and clearly because of the living conditions. So if you want to link with the dermatology, I mean, we have been seeing suffering of people from scabies because the problem at the moment, the scabies, there are people coming and you can screen them on the arrival from Turkey with scabies. But if treatment is not being provided, if the living conditions are not in place, then scabies cannot be treated. So scabies is there. The same goes also with STIs when it comes to no proper screening, also no proper case management of the situation. Now, in front of this situation, the people are also excluded from healthcare system. So from July 2019, more than 60,000 new arrivals, they don't have access to healthcare system except emergencies. So acute cases or chronic cases are not being managed. So in that case, this is something that when you live in an area being overcrowded, the impact on the individuals, but also the rest of the people, it is huge. Now, coming very quickly on the COVID-19, that is becoming, sorry for my French, a sexy topic for everybody. So everybody talks about COVID. Yes, it is nice and important, but when we are asking people to stay home, and you have to ask a refugee which, and he will answer to you which home. When you ask people to wash their hands, they will ask you an answer to you where to wash my hands. And if you ask them, call the doctor, when there is one doctor for 20,000 people, then this does not work around. Now, when it comes to the situation in the mainland, at the moment there are about 200 cases of COVID in the camps. There are 2 camps being locked down and 1 hotel is being locked down. So the camps in the mainland are being managed by Iom on the management, and theoretically overall the Greek government has a responsibility. When my colleagues from WHO, they produce a lot of guidelines, and I think they are very excellent guidelines. At the same time, the pre-screening procedures or the screening procedure that IOM does for people who go mainly on the legal movement as a legal migrant, that is fine. But we are talking at the moment for people, first of all, for the time being, due to COVID, the borders are closed. Due to COVID, people are remaining under quarantine, who doesn't make any sense, because at the moment, people are locked down in the camps in Greece, and the COVID is being continuing transmitted in the camps because there is no proper place. So WHO recommends no quarantine when there are no minimum criteria in place. And when the cases are being managed, everybody says that, well, this Greek government's responsibility. But I think as an international institutions, we have also the human responsibility and the medical mandate in order to come and talk about the situation. I do understand that for a UN organization, it's more and more difficult to talk about it, but I do expect that the data that are being collected, especially that the mental health and physical health of people is in danger because of these conditions, I do expect that probably with your, let's say, magazines you're trying to produce, but also with your collecting of information as medical societies, I think it's important that we come out and talk about unnecessary suffering of these people that is going on not because these people are sick, but because we are making them sick. At the same time, not only we are making them sick, but at the same time, we're not providing them treatment. So I stop here because I think it is something that, you know, it is something that is really makes me sad when I see that this situation, at least in Europe, following the EU-Turkey statement, is continuing for more than 4 years. So at the moment, if we don't change policies the way how we're approaching humans, and we don't consider that there are numbers, nothing is going to change. So next year, when we're going to do the Congress, we have to repeat the same thing. So I think in most of my presentation I've been doing around the world about the issue, most of the time I just change the date of presentation because the picture remains the same. Thank you very much.
Thank you, Apostolos. I share the same feeling, and I agree with you. It's very sad what's going on. The same is here in Malta, and I will show some photo later on. So there are some questions for you, I think, Claire, Apostolos. We have heard that camp directors are reluctant to acknowledge that there is scabies in camps sometimes. Have you had any experience of this? I think
I mean, first of all, let me give an answer on scabies because it's important for you guys that follow dermatology. I'm a general practitioner myself. The point at the moment is that people that they are with scabies, there is no hot water to take shower. There are no possibility to change their clothes. And when it comes to treatment, the AOD with the National Public Health Organization does provide some tons of benzoyl, but that does not work out. We've been calling about the use of ivermectin that could be having a better results on that, but ivermectin is not available in the country. So the idea about recognizing it as an existing problem without giving a solution, it's just a fake solution, asking people, giving them benzoyl when you know the full system does not work out. And on the top of that, we have a lot of children, and we are seeing about 100 children a day that, in addition to the scabies, they have also infection. So you need to treat first the infection, and then you know to manage the scabies, and then you send them people back into the same place. I think you make a circle, and we are seeing even many cases that are being quite resistant on the case management. Now, what Doc Dome is talking about, AOD is responsible for the health in the Greek camps. Yes, it's true that the National Public Health Organization is responsible, but that does not mean that we cannot talk about what they are not doing. So, I mean, yes, they are responsible, but they're not doing it properly. Because in camps, for example, that are managed at the moment by IOM systematically as running the management, implementation of quarantine, when you have an increase of cases on a daily basis in the camps, and the government, what it does extends only the quarantine for 14 days more and 14 days more, that means that something goes wrong. So I think that the idea behind this today, being always constructive with the governments and recommending them properly, I think sometimes it's important to talk about science. And I think what is not happening in Europe, science is not being implemented because, again, I repeat it, and I'm not, you know, I sign it that people that are asylum seekers or refugees in Europe are just numbers.
Thank you. Very tough presentation, and yes, I share your comments and your opinion. I think there are no more questions in the chat, and I think we can close this session. And I welcome also Simon Wiwa, who managed to join us now from Uganda. Welcome, Simon. So I think we can pass to the next session or to the photo of the group. Claire?
Yes, that's right. That's right. Just having been so brutal and cut the other two speakers off without getting a chance to get much of a chat, is that we've also got a moment or two to have any further questions, if anyone.
So we have some time.
Yeah.
Okay. There was a question for Dominic left somewhere here about. I was asking first, there was a question on MSM by Ismail. I lost it.
Ishmael was talking about screening for HIV post-migration.
Yes, post-migration screening, since there are a lot of post-migration infection acquired post-migration. And my question was on the screening, if you use the Cepheid machine for the POCT of CTNG also, not only for tuberculosis.
I can talk about IOM operations, and the answer is that most member states aren't interested in that. So we use the machine at the moment exclusively for MTB. So that's, but it could be used for many things, as you know. The question about MSM screening, I agree. The problem in Europe particularly is that it's most pronounced post-arrival, actually. During the time after arrival, there's a lot of transmission there. In many countries, including the UK, there are recommendations for screening, for example, in primary care, etc. And so, so I think that's the right thing to do. IOM, I wasn't basically, I'm not making any judgment, nor do I have time to talk about all the different ins and outs of screening. HIV screening is something that can be heartily debated, whether it should happen pre-entry, also because there is a question of what that then means and whether you can enter and all that kind of stuff, etc. I don't want to go into this. My talk was more on demonstrating what the expertise is in order to try and tackle the problem. And the problem at hand is this. COVID is and has been traveling, not by migrants so much, but more by travelers, by tourists, through borders. That's how we got it in the first place. Therefore, member states will not open their borders unless they've got some sort of thing, shall I call it, in place. What would that thing then be in order to allow us to do that? And this is one suggestion. Over.
I just wondered, Dominic, one of the thoughts of I had was whether with these migration border health check posts where you can do screening, is there any opportunity to influence the screening that goes on there? For example, is there any opportunity to involve dermatological screening at these sites?
Yes. So the way it works is that this is at the recommendation of the member states. So IOM is at the service, so to speak, of the member state. But we do have an influence. So in normal times, when we have normal lead times, which this actually takes, we can, and we have influence. We have said, look, we find this screening is better than that screening and all the rest. Whether they take our word, because we are, unlike our brothers in WHO for health, not the normative organization, whether they take our advice is another question, but we certainly have that leverage, and we can actually influence that. And yes, I mean, it can be utilized. A lot of the infrastructure is there and could be utilized for whatever. And so we have a COVID vaccine, should it ever happen. If this comes true, then we could be applying it, for example, at the borders as well.
Thank you.
I join a comment of Apostolos who say no screening if no treatment. One of the reasons why we are not screening for HIV at the entrance is also because the country doesn't want to offer the HIV treatment. Is it true? This is my experience, at least. So.
Yes, so HIV screening is a contentious issue, and I think I would welcome to park that, because I thought that my understanding is this is orientated on COVID. I think that any good screening, in my view, needs to be intricately linked into. There's also guidance to that respect from WHO and others. Intricately linked to treatment. And needs to be linked to the health service as well. In fact, if you do it right, then you have a win-win. But if you use it to screen for exclusion, like some of the countries, for example, in the Middle East are doing, then maybe that's not something that we would always find ideal.
Thank you very much. So we might do our photo now, if that's okay. So if everyone wants to just pop their lipstick on, and smile at the camera, or smile at your video. Safia is going to do some screenshots. So Safia will tell us when we can stand down.
Thank you, everyone. I see that there are a few people still that have their videos switched off. It would be great if everyone switches on their video if possible, or I could do it for you. Okay, just waiting, sorry.
Don't wait for me, please. This is Grace.
Hi, Grace.
Hi.
Hi, are you not able to switch your video on, sorry?
Can I skip out of the picture?
So we might, I think we will take it that if the video is switched off, it's because they're in their pajamas, and it's not appropriate, and we'll leave it as it is. But
no pajamas here, but just
Grace will still have your lovely name.
Okay. No, that's I will assume that everyone is ready, and I'll take a picture as is right now, if that's okay. Thank you. Okay.
Done.
I believe I have everyone, so it's 2 separate pages.
Thank you very much. So I'll now hand over to Chris to chair the next session, which is a whiz through of some very exciting things.
Yeah, okay, well, thank you very much, Dan. Thank you so much, Valeska, for keeping to time on the previous session. So this is experience from the field. We've got 6 contrasting lectures, and I do urge people to keep to time so we can have some discussion. So the first one up is a double act. Dr. Tanya Melillo, who's consultant in public health medicine at the University in Malta, and also our previous chair of the previous session, Dr. Valeska Pedavesi, who's a consultant in dermatology and venereology, and they're going to discuss the medical assessment and dermatological profile of boat migrants at arrival and in Maltese reception centres. Tanya, Valeska.
Thank you, Chris, for the nice introduction. Next slide, please. I will try to keep the time. And give you also a brief update about the COVID pandemic also in Malta. In Malta in recent year, we have faced an increase on both migrants arriving from Libya, especially last year when around 3,500 people arrived from the sea. And this has overwhelmed our small reception facilities in the island. And COVID pandemic have aggravated furtherly this situation, with 1,200 residents now under mandatory quarantine in Al-Far Open Center. And as we have said in the previous lecture, it's very difficult to isolate people and to respect social distancing when people live in container, like in these pictures, when there are 10 people sharing the same space and no possibility to divide them inside the camp. The testing are still going on. Next slide, please. And I'm in charge of a COVID unit with migrants admitted from the community, and at the beginning also from Al-Far Reception Center. The experience that I had of the impact of COVID on migrants is mainly on mental health. With the migrants who were diagnosed with COVID, they were at the beginning, they were refusing their diagnosis because feeling well, asymptomatic. This was aggravated furtherly by cultural and linguistic barrier and by the physical barrier, the isolation inside the unit or the fence. And this renewed a sort of experience of detention that they were already living in the past, increasing anxiety, depression, and one of them especially developed aggressive behavior and delusion psychosis, and we have to transfer in a psychiatric hospital. So this was my recent experience with COVID. Next, please. In normal time, next. In normal time, after migrants are rescued in the Mediterranean Sea, they are, the previous one, please. They have to pass through initial reception center. In Marsan, there is a reception center who was on fire last year, and the team of public health performed the medical clearance for public health condition. Next, please. Some photo, simple photo of the team of Dr. Melillo working on the medical assessment, and also the challenging of assessing migrants, a huge number of migrants that has to pass through this center in few hours. Next, please. Sometimes we don't have cultural mediators, so what we have to use is a simple photographic material, simple tools to inquiring about itching, cough, loss of weight, and the so-called syndromic approach. Next. Next, please. Okay. Migrants, the skin, the previous one. The skin is always part of this assessment. The previous one, please. Skin is part of the assessment, part of this syndromic approach. It's mainly for skin infectious disease like scabies. We have toxophara or pediculosis, like in this photo on the right, and tinea, fungal infection, which are contagious and can be transmitted in the community if migrants are moved to the reception, the open center, the reception facilities. Next slide. What we find apart infectious disease are also injuries and traumas, as before was said by the representative of WHO, skin injuries and burn. This is a second-degree burn of the buttock caused by a mix of fuel, salty water, and urine. You have to know that migrants sit for days sometimes, and they are not able to move, and this causes chemical burns. Or in this photo on the right, a secondary wound, secondary to an abscess of lymphatic lymph node tuberculosis. Next, please. Other important problem that can rise in overcrowded detention or open reception center are infectious disease outbreaks like these of varicella or measles, which are common in densely populated refugees camp. And it's very important to detect the case, isolate them, and manage properly. Next picture. So another problem that very important, because dermatologists and the skilled health professionals should detect are skin neglected tropical disease. There is an interesting program in Europe, in African tropical countries about an integrated approach on diagnosis of skin NTDs. But skin NTDs are also increasing in our country, especially in the Mediterranean region, with an increase of diagnosis of scabies, but also cutaneous leishmaniasis, filariasis, and fungal infection. Next, please. Again, we have talked already about HIV acquisition, the high level of post-migration HIV acquisition, with 37% of new HIV diagnoses acquired post-migration, but the number depends according to the study population. What it is in common from the different research publication is that migrants are usually late presenter with a low CD4 count, and they have a poor HIV treatment outcomes. So what we envisage is a common European standard for migrant self-testing at reception and during settlement. Next. We have discussed a lot about screening policy in migrant population, and there is no uniform screening policy in Europe. Most of the country focus only on acute tuberculosis, active tuberculosis, and there is a lot of debate about incorporating latent TB, HIV, and hepatitis into immigrant screening programs. Leprosy is another disease that the screening of leprosy is cost effective if performed in high risk in people coming from high prevalence country and by a skilled health professional. There are no recommendations for screening of scabies and mass drug administration. Ivermectin is cost effective and reduce reinfestation and complication in the camps. And no recommendation about skin neglected tropical diseases. Next. So I would like to conclude briefly, saying that the provision of skin care in migrants is so far inadequate, and there are a lack of recommendation and guidelines in Europe. Challenges are related to the poor access to service and essential medicine, lack of trained healthcare professional, linguistic and cultural barrier, mobility of this population, and legal entitlement to care. Other problems concern also sexual violence, especially in Libya. We have faced a lot of women migrants coming from Libya, all sexually abused. So screening for STIs, HIV is mandatory in these cases. Torture and the skin sign of torture, but also the mental consequences with a post-traumatic stress disorder and the form of exploitation, mainly human trafficking. So with the changing landscape in terms of demographic migration, this COVID pandemic, migration will still continue to occur. We have seen both migrants trying to reach our countries, Italy and Malta, in the last few weeks, but re-enter sent back to Libya because our ports were closed. So therefore, advocating for skin health for all remain extremely important for us. And I thank you for the attention.
Okay, thanks so much, Valeska. We have time for one question, a brief question if anyone has one. If not, I'll just ask you the one question, Valeska. Do you see any huge difference in the conditions you see from different countries that are coming, the nationalities that are coming through, or is it pretty homogenous, really?
I mean, the condition at arrival are pretty much related to the travel condition and the living condition in Libya, in the detention center. So I work in Lampedusa with the NMP, and I face the same experience and the same skin condition that I'm seeing here in Malta. So there is no huge difference. I work in the Syrian, with the Syrian in Jordan, in the refugee camps, and the skin condition there were again different because the population and the prevalence of diseases is different. So in that condition, that environment, I saw mainly skin inflammatory condition like dermatitis and less infectious diseases. Also because those populations had a better access to healthcare inside the camp.
Okay, well, thanks so much. That's a very nice overview, and thank you for keeping to time. We now will move to Ethiopia, and very pleased to welcome Dr. Mbiali, who's a dermatovenerologist working from Bahir Dar University, and he's going to talk to us about scabies in internally displaced persons in the Amhara region of Ethiopia. So, Dr. Mbiali, welcome.
Thank you. My presentation will be on scabies, the different crises that is internal people. And next, please. And so the outline of my presentation will be, I will see that the IDP crisis and its trend in Ethiopia, and I will see the basic services on those internal campus and the scabies assessments we did, and we'll conclude. Go with conclusion. Next, please. Next, please. So when it comes to in Ethiopia, this is clashed in different parts of the country. Forced to displace 3 million people from their home since beginning of 2018. And in January 2019, when the peak to around 3 million people in the country, in around 800 displacement camps. Next, please. Next, please. So when you see the trend, you can see that just the trend was increasing and peaked in January 2019, and we collected data in May to June in 2019 when the displacement was around 1.6 million people. Next, please. We'll see the basic services, those settlement titles, which still hasn't changed. Shelter are below the standard with overcrowding, and there is, for example, one toilet in average for 1,160 people. And next, please. And the same goes also for the other access, especially water and healthcare. There is 3/4 of the population has healthcare access, but around 50% of those clinics, they don't have even the essential drugs. Next, please. Next, please. So the most important disease which has been reported on those refugee camps were malaria and diarrhea in most of them. There was a report of scabies in the Amhara region following in around 14 campuses with prevalence of 3%. Next, please. So the study objective was just to validate this report from the sites and determine the prevalence of scabies on the IDP food distribution centers. Next, please. So we did some cross-sectional study in those in the food distribution sites, and the result was around the prevalence of scabies in this area was like 1%, and mean age of those people was around 22 years, and most of the patients were symptomatic. Next, week. Next, please. And 2/3 of those 8% of the adults and 61% of under 50 children have lesion in regenital region, and 2/3 of those patients treated for scabies before in the last 2 years. They are exposed especially with BBL and sulfur. Next, please. And almost half of those patients didn't have the access for health care. Previous slide, please. Previous slide. Yeah, almost half of the patients don't have access to the health facility, and 9% of patients have critical shortage of water, and 7% if they don't have the hand washing material. There was no single actually shower from those sites, and so most of those patients, they wash their body in the river. And next, please. 48% of the adult patients have no basic knowledge about the scabies and compared to without scabies, and 6% of patients claim to be in a single room with more than 5 family members. And the family size was significantly associated with increased scabies prevalence. Next, please. Next, please. Yeah. So in conclusion, next, yeah. In conclusion, the poor knowledge on scabies, prevention diagnosis, limited water access, overcrowding, and poor access to health facilities were the risk factor, and the access for water and the campsite hasn't been changed from the report to a danger for the increased COVID transmission if the epidemic is going in the country.
Wendy, I'm just wondering if you could just speak right into your microphone. You're drifting in and out a little bit, if it's possible. Thank you.
Okay. So the health service of these internally displaced sites need to be strengthened. That was our recommendation, and the health education and sensitization about scabies prevention and control is important. So keeping personal hygiene need to be given. And that's all my presentation, and thank you.
Okay, thank you so much, Wendagan. Some very important public health messages there. We've got a couple of minutes for questions. I just wonder whether Claire Fuller wanted to ask something specific, having interest in scabies, and any specific questions about what we've just heard.
Well, I'm fairly familiar with Wendy's work, but Wendy, I just wondered if you wanted to sort of bring out the human aspect of what those patients have been experiencing, which you shared so eloquently previously, about how dreadful it is for this community with their severe infection.
Yeah, the issue is those patients, especially scabies in that area, as more than 62% of people they have bacterial infection, and it's difficult. Yeah.
Can you speak into the microphone, please?
Yeah.
Thanks.
Can you hear me now?
Yeah. Good. That's good.
Most of the patients, when their living condition is so compromised that they don't have even access for washing, and there is super infection. What we found is that actually from the other population, there was really an increased prevalence of bacterial super infection. So those people, they can't even work this area. And the other issue is they don't have even access for treatment, and they are accessible. Most of them, even if there is health facility, they don't have the drugs. And I think that's what.
Could I just also follow up with that? So Wendy Megan, I believe at some point you were able to procure some ivermectin in large quantities. Is that something you can discuss with us?
Yes, that's the positive side in our studies. After we found out there is this scabies epidemic going on those campsites, we did have the access for both ivermectin and permethrin, which is procured by the government. And now we have a constant supply of actually ivermectin, which has been shifted from the ONCO program, plus also procured by the government. And that's the thing of the, yeah.
Okay, well, thanks so
To
much.
answer your question, yeah.
Yeah. So as you say in your slides, well, that was some wisdom from the source of the Blue Nile. So thanks so much for that, and it just re-emphasizes the importance of public health in all of this. So thanks. We're keeping very well to time here. So we move on to our next presentation, and it's my pleasure to introduce Dr. Sue Lewin, who's a dermatology registrar and also an honorary clinical research fellow at Guy's and St Thomas's Hospital and King's College, London. And she's going to discuss with us the Burma Skincare Initiative and internally displaced persons in Myanmar. Sue.
Thank you. Thank you, Chris, very much for your introduction. Can everybody hear me all right? Because I just want to make sure that audio is all fine before I carry on talking.
That's good.
And thanks to Claire and Valeska for inviting me to speak. And this is a very exciting opportunity to share with you our work on Burma Skincare Initiative and the IDPs in Myanmar. So next slide, please. So in the interest of time, I'm going to touch on the content, so that these 4 different sub-headlines of the talk. There is so much to say and so much has been achieved in just over a year, so I will try my best to keep it succinct. Next, please. So Burma, as most of you know, it's a Southeast Asian country, and those who have traveled to Burma hopefully would agree with me. It's a really beautiful country with diverse landscapes, population of 53 million approximately, and 135 ethnic groups with their own languages. And absolutely the diverse landscapes, of course, means that the skin pathology that we see in each region is quite different. However, despite the beauty, it has one of the poorest healthcare systems in the world. And the WHO in 1997 ranked it as 190 out of 191. Next, please. So in terms of dermatology, there is quite a lot to be done. And of course, majorities of people don't have access to skincare because there are only 3 specialist centers for dermatology in the country. 2 in Yangon, which is marked by the blue and the red triangles in the south, which is the economic capital, and 1 in central Myanmar in Mandalay. Next, please. So in December 2018, Professor Griffiths and I traveled to Burma and visited the dermatology centers and met with the Myanmar dermatologists and dermatology trainees there. They were very, very enthusiastic about what we're trying to achieve, which is to try and remove skincare access, to improve the barriers to skincare access in Myanmar. Next, please. So we did a few ward rounds and had the opportunity to see the patients on the ward as well as in clinics. And as you can see here, pemphigus actually seems to be particularly problematic for them. And part of the reason is because there are no immunodiagnostic labs. But in addition, just as Valeska has beautifully illustrated, the skin-related NTDs are also really a big issue, as you can see on the picture in the far right here, mycetoma and chromoblastomycosis. And psoriasis patients, for example, they have very limited access to systemics such as even methotrexate. Next, please. And so we had really exciting discussions with the local Burmese dermatologists, and having identified their unmet needs, this is quite vital because we want to do what is actually needed on the ground. And as you can see, there are several challenges. But these challenges, in fact, of course, for us are, next slide, please, are opportunities. And based on these opportunities, we have strategically sort of formed this Burma Skincare Initiative. Next slide, please. And of course, the overarching aim is to remove barriers to skincare access in Myanmar. And our mission is founded on the 3 pillars. Always there are 3 pillars, of course: education, research, and clinical. And I'm really delighted to tell you that it is now a UK registered charity. So anyone willing to donate, we are more than happy to accept. And of course, it is about sustainability, which is key. Next, please. So this is a very busy slide, and you can see that we have strategically formulated our goals as short-term, medium-term, and long-term within these three domains that I mentioned in education, research, and clinical. But I just want to highlight here that the ultimate goal that we want to achieve is to establish a regional dermatology training center, as you can see, RDTC, hopefully in 10 years or before that. The boxed areas are the ones that we have either achieved or are in progress at the moment. So I'll take you through the highlights of that now. Next, please. So a few highlights. In 2019, for the first time ever for the Burmese dermatology trainees, they had the opportunity to attend an international dermatology meeting abroad. So that was in Bordeaux, France for the ESDR meeting, and they were absolutely delighted. Next, please. And in 2020 February, Professor Griffiths and I returned to Burma and conducted mobile and impromptu clinics in the regions as marked in red on the screen here. Next, please. So we had a chance to visit a nunnery orphanage, which was a very, very special and moving experience. So you can see in the pictures, these are orphans from victims of internal wars, just as in Ethiopia, and they are indeed internally displaced, and most of them had really traumatic experience in the past. And you can see from the skin point of view, scabies, infected eczema, and tinea are prevalent. Next, please. So another really different experience was a township hospital visit in the southernmost part of Burma. And this was a 100-bedded hospital serving a population of 500,000. And only one physician actually looks after all the patients, including those with skin diseases. Next, please. So the ultimate highlight for us was the first ever international dermatology meeting that was successfully held in February, to which Dr. Claire Fuller also attended. And it was attended also by more than 270 attendees, delegates across Burma. And one day was fully dedicated to the nurses, and that was first time ever that occurred in Burma. And on the last day, we had the sustainability roundtable where we strategically plan what to be done next. So next, please. And our next steps are, next, please, the workshops in 2021 on psoriasis and global psoriasis atlas, as well as eczema and allergy. We are already planning on that. And fellowships are coming up, and some are already announced. And in education and training, we are working closely with the RC Royal College of General Practitioners to develop a dermatology component of their family medicine curriculum in Burma. And in terms of research and diagnostics, we have two projects that we're working on, Pemphigus project and Macadamia. I love the name Macadamia project. Of course, that's credits to Professor Griffiths. And it is a project on mycetoma and chromoblastomycosis. And Professor Rotte in the audience is a collaborator on this project, and we're absolutely delighted to have him. And importantly, last but not least, very importantly, teledermatology is something that we're very much interested in developing. So hopefully we can discuss with Professor Toby Mora. So I only have three more slides, and I'll finish very soon. So next, please. And teledermatology is particularly relevant because of the IDPs who are displaced across the country. And you can see there are four main regions marked in red: Kachin in the north, Shan in the east, Kayin in the southeastern, and Rakhine, of course, as well. We all know about Rohingyas, which Sidra will talk to you about in a moment, but there are those who are actually remaining in Burma, in Rakhine State, who are also IDPs. There are almost quarter of a million people there in Burma. Next, please. And of course, these are vulnerable groups of people that everybody have had the same sentiments about. And Burma is facing really, really difficult challenges and even turning meditation centers as quarantine places in Burma at the moment. And I shall stop here in the interest of time. And as the last slide, the key message is that we are dedicated to removing barriers to skincare access in Burma in a very sustainable manner. Thank you.
Thank you so much, Sue. A lot to get through there, but some exciting work. We've got time for one quick question if anyone has one. I haven't seen anything come up on chat about that, but we'll probably have some time at the end of this particular session to come back and discuss. So thank you, Sue. Very neatly, this segues into the next talk, which is by Dr. Sidra Khan, who is a specialist registrar, dermatology registrar in Manchester. And she, in effect, led a group of us, including myself, Dr. Toby Mora, and Dr. Valeska Belavezi, to visit the large Rohingya camp in Cox's Bazar in Bangladesh. And she's going to give us a report on what she and the team found there. Sidra.
Thank you. Thanks for the introduction. Can everyone hear me okay?
Can you speak a bit louder, perhaps?
Yeah. Can you hear me okay now?
Yeah, that's great.
Yeah. Okay. So I'll be very brief. I'm just going to give an overview of our recent mission to Cox's Bazar in December. Next slide, please. Just a little bit of background. So the Rohingya refugees are a Muslim ethnic minority group, as Sue mentioned, who reside predominantly in the Rakhine state of Myanmar. Following the outbreak of violence in August 2017, large masses fled into the Cox's Bazar district of neighbouring Bangladesh. They entered various different settlements, the largest of which is the Kutupalong refugee camp. Next slide, please. So the population is now estimated to be approximately 800,000, making it the world's largest refugee camp. Healthcare is fairly basic within the camp. There's a mixture of primary care clinics, vaccination centres, and multiple field hospitals at the periphery. With regards to skin disease within the camp, there is very limited data, but what I was able to find prior to our mission was the table over on your right from the WHO. And as you can see, between August and December 2017, skin diseases were actually the 4th most common presenting complaint to primary care clinics within the camp. I was able to get a hold of monthly figures from a single clinic, and that also showed that they saw over 300 cases of patients presenting with skin disease in just 1 month. Next slide, please. So our goal is to improve access to dermatology care within the camp, and part of that involves developing a better understanding of exactly what is the dermatological needs of this vulnerable group. So a group of 7 of us headed out in December to run 3 days of dedicated dermatology clinics, and we were supported by the organizations listed below. Next. So what did we find? So across 3 days, we saw 380 patients and made 457 clinical diagnoses. And if I can just draw your attention to the table over on your right, as you can see, we saw huge variation in cutaneous disorders, and probably what you would expect. We saw a lot of infections, but a fair amount of inflammatory dermatoses as well. But what I want to highlight is really the proportion of patients that we saw with fungal skin infections. And as you can see, fungal skin infections made up almost 2/3 of all diagnoses made. Next slide, please. And in particular, it was dermatophyte infections that we saw. And if we break that down further by age and gender, you can see that although in earlier ages, male and females had fairly comparable figures, from the ages of sort of 15 and upwards, we saw much larger numbers of women that were affected with dermatophyte infections, and in some age groups, almost double their male counterparts. Next slide, please. What was also very striking was actually the type of dermatophyte infections we were seeing. We were seeing very extensive multilesional tinea corporis affecting large body surface areas, and it was predominantly women of a reproductive age. And this raised a number of questions which have already been brought up previously about HIV services and testing and treatment within camps, so I won't dwell on it, but this was certainly a question that was raised by many members of our team, and the lack of facilities available for this very vulnerable and at-risk group. Next slide. So just to sort of summarize our thoughts from that particular mission, we saw a wide range of dermatoses, and it was fairly similar to data published from refugee camps in other countries, but there was certainly much more fungal skin infections seen in this particular group. Predominantly, it was extensive and multilesional tinea corporis. This raised many questions about the underlying health status of this vulnerable group. Should we be screening for HIV, diabetes, etc.? And of course, the answer is yes, but there is very little provision for HIV testing within the camp, and certainly no access to antiretroviral therapy. The other thing I just want to touch on, which I haven't really dwelled on, was actually we saw very little scabies. Across the 3 days, we only saw 16 cases, which in itself is quite interesting, given previous presentations. And we know that this is a problem in other refugee camps around the world. And perhaps it was due to the season or the particular environment that we were in. Next slide. So looking ahead, so one of the other goals of our group was to set up a teledermatology clinic. And I'm pleased to say that hopefully we will be starting the pilot very soon. The project has to change shape a fair bit due to COVID-19, but we're doing this in collaboration with the Department of Dermatology in Chittagong. There is also further work, I believe, to be done really in understanding more about the dermatophyte infection scene in this particular region. We brought back some skin scrapings and Professor Richardson at the Mycology Reference Centre in Manchester had been analysing these for us, and predominantly what was seen was interdigitalis, but he's hoping to do further work on looking at fungal resistance as well. The formulary that we were working with was fairly limited, and there certainly needs to be more work done to improve this. One of our members, Bayan, is working currently on developing targeting teaching tools, and there's huge scope for that as well. And as with regards to an update on COVID within the camp, as far as I'm aware, they're not testing, so there are no confirmed cases, but there is one confirmed case of COVID-19 in the Cox's Bazar district. This is obviously felt to be a huge underrepresentation, as the government aren't really doing as many tests as the healthcare staff on the ground would like. But the government have certainly stepped up security and rules and tightened security around the camp. There is armed military at the periphery, and they have limited the amount of international staff that are able to enter and exit. So again, you know, certainly making the case for us to really push ahead with our Telederm project now more than ever. Next slide, please. And that's me. Thank you very much. And I just wanted to say thank you to our collaborators as well, the Refugee Crisis Foundation and the OBAT helpers. And we did receive some funding from the American Academy of Dermatology and the BMA. Thank you.
Okay, thank you so much, Sidra, for keeping to time there. So we've got a few minutes for questions. One question that's coming through is around this observation about the tinea corporis, and seem to be quite a high prevalence there. And I mean, if you want to expand on that, I mean, one discussion point is around whether these people are immunosuppressed. And so two questions really. One is whether, you know, the HIV status of these patients, and also to circle back to what, to question to Sue, because of, you know, these people are all coming in from Myanmar, and what the situation is as far as HIV is in Myanmar. So Sidra, you first.
Yeah, no, that was certainly our thought. You know, there needs to be more done with regards to improving HIV testing and treatment. And there have been a few papers published, I believe, in the Lancet over the last couple of years, where multiple clinicians have raised concerns about the HIV or the under-testing and screening of HIV for the Rohingya group, largely because, you know, they are a vulnerable group. There have been high reports of gender-based violence. There was a concern about the HIV sort of epidemic in the early 1990s in Myanmar. So it's multifactorial, and it's certainly something that has to be addressed. In my view, and certainly what we saw, it was women predominantly of a reproductive age. Of course, what we saw was just a small number, and there were certain biases in our group, of course, but I think certainly an important starting point.
So any comment from you about HIV in Myanmar?
Absolutely. So HIV, definitely, there is always an underestimation of prevalence and incidence data of anything in Burma, Myanmar, and predominantly because there are a lot of people with no identities. And there was a case published in BMJ in 2013. There was of intravenous drug users and non-drug users, and how much they actually took up the testing. But also, of course, it's a huge stigma in a place like Burma. So there's quite a lot of work to be done, and we don't have any data at all whatsoever about the IDPs and the HIV prevalence at the moment.
Okay, thank you, Sue. And we've got a little bit more time. So another question that's come through, and that's from Nikosa Delova, and of course it's an observation. You know, we considered when we were there, because of, you know, these skin signs may well be not just relevant to maybe underlying immunosuppression, but also systemic disease such as diabetes. And I don't know if you want to answer that, Sidra, about what we know about the prevalence of diabetes in this particular group.
That I don't know about. Certainly I guess the population is a fairly young population, but I don't know exact figures about the incidence of diabetes in the group.
But I guess it's the great thing about skin disease is that it's flagging up serious systemic issues, isn't it?
Yeah, and it certainly opens up the gateway to collaborating with other healthcare professionals, and having a sort of combined sort of approach, because skin disease lends itself quite well to that, and to wider global health issues.
That's the message that's going to come out of this meeting, I think, is that the importance of skin disease to systemic disease. And of course, we always get pushback, well, what's the importance of skin disease? Well, all the links to systemic disease, whether it be cardiovascular disease, chronic kidney disease due to scabies, and then these markers of underlying immunosuppression. Great. We now should move on and now move into Lebanon. And Dr. Ismail Matouk, who is a dermatologist and STI specialist from Clemenceau Medical Center in Beirut, is going to talk to us about STIs in Lebanon, and particularly in the refugees, the Syrian refugees, particularly in Lebanon. So Ismail, off you go.
Thank you so much, and thank you for having me on board. I will be speaking about STIs in migrants, especially with the Syrian refugees era following 2011. Next, please. So I have no conflict of interest. Next, concerning the Eastern Mediterranean region, we have basically two main problems. One of them is that the HIV is prevalent among key populations who are usually stigmatized and discriminated. And we have the second problem, which is the very low, among the lowest targets of UNAIDS by which are the testing, people who are aware of their status, people who are taking their ARTs, and people who are virally suppressed. We have the lowest rates in all the WHO regions. Next, please. Among the prevention tools basket, we have only two which are in place: the circumcision because of religious beliefs, and the harm reduction. However, we lack of the STI care, diagnosis, treatment, condom use, PrEP, and mother-to-child transmission surveillance, and also treatment as prevention, because the majority of people who are living with HIV do not, and who are aware of their status, are not virally suppressed. Next, please. Concerning ART coverage, it ranges between 8 and 64%, which is not very good. As you see. Next, please. Lebanon and Morocco, for example, also. There are some countries, including Lebanon, who have completely different achievement for concerning HIV epidemic. So next, please. We have achieved at least the first 90 for people who are aware of their status, 94%, and retained in ART or in care 64%, and virally suppressed almost 60%, which is, we have a lot of work to do, but at least we are better than our neighboring countries. Next, please. The prevalence of HIV in men who have sex with men is 12%. Next, please. I'm talking about Lebanese Msm. Starting 2011, we had the Syrian crisis, our neighboring country. And as you see, we have one characteristic: we don't have a lot of camps, specific camps dedicated for Syrians. We have Syrians who are widespread present in the whole country, or who live in the already present Palestinian camps, like the one which is called Shatila, where I had the chance to visit and to work with Professor Morone. Next, please. So I was there in between 2013 and 2014 with Professor Aldo Morone for specific skin consultation, and with very few STIs diagnosis and consultation. Next, for the few slides, please, because there are only photos. So next, just to show you the general overview of this historic camp. Next. Okay, concerning some numbers, If we want to compare between the Syrian refugees and the Lebanese MSM, we're talking only about MSM, our latest findings show that Syrians are more frequently married to female partners. They are more, they have more sex work, commercial male partners compared to Lebanese, and the average payment or the price of the work of the sex act is lower, which it's $40 according to our latest IBBS. Next, please. Concerning the number of commercial partners, as I said, they are high. They are higher than the Lebanese ones, at least in a month, and the non-commercial partners are lower. Next, please. There's an info which was missed somewhere because there is a delay with the slides, where usually MSM, Syrian MSM, do not self-identify as MSM. So they have current female partners, and they are more married. This is one. The condom use among commercial and non-commercial partners is usually lower than Lebanese MSM. Next, please. Concerning alcohol and drugs, there's more reported consumption among Syrian MSM, whether it is chemsex or not. Next, please. For stigma and discrimination, you understand how they are more stigmatized when it comes to verbal insults or harassment, housing, and employment, which makes the gap even more pronounced. Next, please. Concerning STIs, we have more reported symptoms. Of course, the price of the PCR, which is expensive, is a constraint against being tested. HIV knowledge is extremely low, 18%, and whether those were ever tested for HIV is almost 50%. Next, please. So among all these challenges, as I explored I proposed to you very quickly, we have the bridging effect from male to female and from non-Lebanese to Lebanese. We have the internalized homonegativity to be explored by its own. High stigma, low economic status, condomless anal sex, drugs, alcohol consumption, low knowledge about HIV, and low testing for HIV. Next, please. A newer study conducted last December showed similar findings with poor or very poor socioeconomic status, and again, low condom use and low vaccines status for hepatitis B and of course HPV, which is not covered by the government. Next, please. So these are the new challenges that we found with this newer study. All this risky behavior profile contrasts with the next, please. Contrasts with the prevalence of HIV and of syphilis that we found. Next, please. Which were 3% for HIV and 0.3% for syphilis. So among all these challenges, we have to add, of course, and never to forget, next please, the programmatic challenges, the lack of human and financial resources, and the surveillance, of course, because it's difficult when you don't have one camp, when you have people who are widespread to be testing them and to have the surveillance accurately. The tests and who finance the test, of course. And we have the social challenges like the stigma, family support, cultural barriers, etc. So with my final slide, next please, I wonder how the Eastern Mediterranean region and Lebanon, who is doing extremely well compared to other countries, how we will contribute to improve the HIV and the sexual health in light of SDGs, and despite all the efforts and those guidelines published by WHO for HIV, STIs, and viral hepatitis. Thank you so much.
So thank you so much. That's a very powerful presentation. I guess there's a couple of questions come through on this. I think a particularly highly relevant one from Toby Mora about, you know, this is very impressive information that you've acquired from these people. How do you gain their trust to be able to talk to you about this? because I guess you've got to have them relaxed and be able to discuss their sexual activity. Do you?
Yes.
Can you share some of that with us?
Yes, of course. First, I have to say, because I know from colleagues and friends that they are usually afraid when I mention MSM in Lebanon, we are much better and less stigmatized in this country compared to other countries of the Middle East. So it is somehow different than the Middle East ambiance of while talking about MSM and while dealing with sexual health. What we do actually in Lebanon, we have civil organizations who deliver the services on behalf of the governmental program of HIV, which is a joint program between the government and WHO. So we have this umbrella of the WHO, which makes us more at ease while discussing sexual health, HIV testing, condom use, even PEP, which we deliver for free for Syrian and non-Syrian and Lebanese, populations. So it is somehow more accepted to talk about sexual health in Lebanon, and the civil organizations have or play a major role in delivering services anonymously for free for these communities. Thank
you, Ismail. So we should move on, and I'm not so sure whether we can move on it because is Dr. Mwima still with us? Simon?
He's not.
No. Okay. So Simon was unfortunately called to I think a crisis at the Tanzanian border. Simon is a doctor working, particularly an epidemiologist, but working in the Ugandan Ministry of Health, and he was going to share his experience with us. But I think a sort of fairly acute situation has overtaken taken him there. And though he joined us very briefly at the start of the second session, he was not able to stay with us. So hopefully he'll be able to share his lecture with us at some later date. But that does, I guess, give us some time, not the whole 20 minutes, but 10 minutes to circle back and discuss a little bit more about what we've heard in this session. And then also I can generously give Professor Mora an extra 10 minutes for her session as well. So one question that's come up, and I'll be interested to get a response from the presenters we've just heard, is about the need for an essential formulary. Certainly what we discovered in Bangladesh, and I guess that others have discovered in Burma and Ethiopia, and maybe also in Lebanon, and maybe in Malta as well, is what are the essential drugs that we need to have on a formulary or be able to recommend that these camps have to be able to manage, not every condition, but a sort of a good range of conditions. So I don't know who wants to start with that. Perhaps Citra, you could start. I know we experienced some of that just a few months ago.
Yeah, absolutely. I mean, just from listening to all the talks this afternoon, there's certainly some degree of variation with regards to what is more prevalent in certain camps. Our experience was that scabies was not that common, and we didn't plan for that. We had brought along a lot of permethrin and not very much antifungal therapy. And in fact, we ran out of all of our antifungals, and we had to sort of go on the second night into the market and purchase more antifungals from the pharmacies in the market. So I guess it will vary slightly from each country to country, and certainly more exercises like this and needs assessment sort of trips to sort of figure out exactly what the dermatological needs in each different group are. And it will vary, I suspect, season to season as well. We went to Bangladesh during the cold, dry season, and I suspect that might have maybe influenced maybe what we saw a little bit as well. But I'm sure it will vary from camp to camp.
Okay, thank you.
Could I?
Yeah, Sue, yeah.
Hi.
Sure.
Absolutely, as Sidra said, it will vary from camps to camps, but in our case, I mean, as you know, Chris, it varied from monastery to monastery even, because when we did the nunnery and the monastery visits in central Burma, we saw a lot more scabies amongst the boys, but not amongst the girls. So that may actually indicate the sort of hygiene issues fundamentally too. But the challenge that we did have was most people resort to the traditional remedies, traditional herbal remedies that are available locally. And we have no knowledge of that, of course. And that's a major challenge. So what we did do was actually, with the help of a local person, we collected the names of all the Burmese remedies available, and this is what we are actually looking into with the help of local Burmese dermatologists, because I think it's really essential. And also I'm sure in some parts of Africa and other countries as well, that is maybe the case. So I think we ought to perhaps bear that in mind as well.
Okay, thank you, Sue. How about in Ethiopia, Morgan?
In our setting, actually, it's not only for the refugee campus. We tried to, the beginning of or last year, we moved in certain campus, even with Professor Aldo Morone, and this almost, the dermatology medication are almost non-existing. The only better thing in our country is because of the constant scabies outbreak. We have secured the ivermectin, but the other medications are almost inaccessible, and most of the refugees who are living with the host community are also their addition to the healthcare load. So the health centers are actually incapable of providing for such medication. So that's the reason almost 50% of the health centers we evaluated, they don't have the essential, even the basic medication, not only for dermatology condition, but also for the other health services.
Okay, thank you. And then Valeska, what sort of formulary do you guys have for those reception centers in Malta?
It's quite limited.
Is it linked into the main system, or do they have to have their own separate pharmacy and formulary?
No, migrants and refugees, independently from the status, once they are in the reception facility, they can have access to healthcare. So both primary care and secondary care. So dermatology consultation and STIs consultation. So they can be referred to the hospital and they have a dermatological assessment and free medication. So it's the same medication of the people in Malta. But the problem is when there is an outbreak in the camp, so the availability of ivermectin is very limited in Malta. And also we discussed a lot with Dr. Melillo. We have a few tablets of ivermectin and we keep them like gold, basically, for the most spread scabies, for crusty scabies and the most serious condition, whereas mass drug administration, some studies show is very effective in controlling the outbreak in a camp. So we should advocate for that, I think, ivermectin, which is expensive, I think, in Europe. That's one of the limits.
Okay, I agree with that. So
other medication, in other experience, like Sidra say, depends from camp to camp and according to different setting. Like when I work in Jordan, I saw a lot of inflammatory condition of the skin. So steroid were the most used treatment. So topical steroid, we had just two different kind, mild, light topical steroid like hydrocortisone and clobetasol, so the two extreme. And that was all basically, and emollients. It depends from the setting and what you are facing, basically.
Thank you. And then to Ismail, when I visited the Syrian refugee camps in the Bekaa Valley in Lebanon in 2018, I visited two of the camps there. We had to take all of the pharmacy. Well, actually, had to take the pharmacy with us. They had no drugs there at all and no supplies, and we had to do that ourselves. And I don't know what your experience is, because obviously, particularly for treating HIV, I mean, how does that happen? How can you?
The only exception actually is for HIV, because ARTs are provided through a grant from IOM and WHO to Syrian refugees, which is called the Middle East Response. So they started this 3 years ago, and now they maintained another, so the part 2 of the response. So we provide the HIV treatment for free for any refugee, because we have a lot of refugees. We have Palestinian, we have Iraqis, we have Syrians, we have Kurds, etc. So they get it for free. For other medications, no, they have to pay. Even for syphilis, for gonorrhea, for any consultation, they have to pay.
Really, thank you for that. And Apostolos, you have a comment on this.
Yeah, I think we need to discuss two things. First of all, in addition of making available ivermectin, that I think in our projects worldwide, we use generic ivermectin as a cheap one, not expensive one in Europe. In addition to that, I think for many situations, if the living conditions and are fine, people, they don't need to have skin diseases related to living conditions. I think we need to advocate for both. And I think the essential drug list that can be available in the camps would be also minimizing the difficulties of referrals, because maybe in Malta it's easy, but in many places the referral is very complicated. And I think the training of the staff who are offering primary health care on the basic things of dermatology, it is important. But again, coming back, what we've been seeing as experience, there have been only a few cases of real dermatological cases. Most of them are produced in the camps.
Okay, so this is triggered a lot of discussion, and which I thought it probably would, just from personal experience. And Toby Moore has also raised the important point, which we discovered for ourselves. You heard about Sidra and Toby going to the local high street, so to speak, local roadside pharmacy and bargaining for fluconazole. But I don't know if you want to tell us a bit about that, Toby, because it wasn't quite what it seemed.
Sure. We had heard that there was possible resistance to topical antifungals and oral antifungals, that many patients within the refugee camp actually had fluconazole, but just weren't getting better on fluconazole. And so we started to think, well, is this due to resistance, or what medicine is there? Is there fake medicine potentially out there? And so when we were on the market and trying to bargain, we found more expensive fluconazole and less expensive fluconazole. And we had heard that perhaps it was not what it was advertised to be. Some fluconazole actually didn't have much ingredient in it. And I think that this is a big problem throughout the world, that many drugs are sold without the active ingredient. I just want to make a push for testing that. And we have been fortunate enough to work in Kenya with a very brilliant pharmacist who was able to test for active ingredient by really placing a very small card within in a medication that's kind of crushed up into water to look for real ingredient. It's very inexpensive. He is trying to push this throughout the world, but I would say that as we think about resources to really test for active ingredient.
Thank you, Toby. So before I hand over to Toby with the extra time that I'm about to donate to her, a couple of things, three things that are coming through here. One is about this essential medicines and where they should link into the WHO essential medicines list, and that's a sort of separate discussion, but something to bear in mind. The second, which has come through, and I think is very important, of course, and something we saw in Bangladesh, is that there is a growing resentment from the local population about the investment in healthcare for the population of the camp. And I think when we're doing this work, we always need to be aware of looking after the local population, not just the people who are in the camps, because there is definitely a dichotomy there between the two. And I don't know if Toby or Valeska or Sidra wants to comment on that, but certainly that was an undercurrent of unhappiness. And that's certainly what the Bangladesh dermatologists were sort of saying to us. Well, it's all very well us going to the camps, but we've got enough problems dealing with all our patients back in Chittagong.
Just while they're thinking about responding, I wondered whether that is actually something that we would include if we develop some sort of rules of engagement or guidance or recommendations for developing any projects around displaced persons camps, that we would think about very much about the local population. Rod's got his hand up.
Yeah,
Rod,
I can see that, yeah.
Say something.
Rod.
Yeah, can you hear me?
Perfectly.
Okay, it's sort of relevant to this because what you're seeing in Cox's Bazar is identical to what the Indians have been experiencing as a huge outbreak of tinea corporis in normal people. And the suggestion is that it is in Bangladesh. And so actually this would give an opportunity to help both the local population, because I suspect it's in the Bangladeshi population, caused by this funny organism, which is a bit unusual. And you could kill two birds with one stone by helping them plus the displaced people.
Okay. Thanks, Rod. So I think what we should do, this has also prompted a lot of discussion around how do you diagnose, how do you run a service for displaced persons, both internally and in the refugee camps outside their own country. And one option, which has got a lot of traction in what I've seen on the chat line, and certainly we've discussed in detail, sort of the group here in Manchester and one patients we saw in Burma as well, is around the utility of virtual health and teledermatology, and maybe AI for making diagnoses without recourse to a dermatologist. But with that, and it's a sort of nice way to hand across to Toby Mora, who is sort of UCSF, but also Indiana. I'm not too sure who you truly represent now, probably Indiana. And you're going to talk to us about virtual health and share this sort of discussion session about virtual health, particularly in the current time of COVID-19 pandemic.
Thank you so much, Chris, and the organizers of this conference. It really is a pleasure to come together, all of us, to think about these very major issues, and especially during the time of COVID. I have been very intrigued by what COVID has really made us think about worldwide. I think it has become, in a sense, the great equalizer, if you will. It has alerted the world and made people stand up to think about what it means to be socially isolated, questions about food security, transportation, decreased funds, decreased access to health systems, and more health problems that are coming up. I think that most of the developed world certainly was just going along its wonderful way and not really thinking about any of these issues. While many of us were trying to bring up issues that we all think about every day, there seemed to be complete lack of interest, if I could say that, by most people in the world. That has changed in the last 3 weeks with COVID. And most certainly what we have seen is that because there have been decreased face-to-face visits with our patients, this has prompted an explosion, if you will, in telemedicine and the need for telecommunication. This to me has really presented an opportunity, if you will, sort of looking at this idea of never let a good crisis go to waste. And I think we have hit a huge crisis in the world that has demanded a need for telecommunication. And with that, I just want to really say, maybe we, as people who care about migrant health and health for vulnerable populations, should take advantage of this opportune time to really explore and perhaps implement telemedicine wherever we can. In the chat box, I certainly did see suggestions for various platforms that were out there for telemedicine. And I'm going to ask Claire in a moment to really go through those platforms and talk, bring them up to the audience here, and we can talk a little bit about the various platforms. But this is just to say that there are several solutions out there, several platforms, and I'd be interested to hear from our audience about some of the challenges of implementing those platforms. I can most certainly think of some of the challenges that I have faced. Number one used to be lack of interest, and now suddenly there's too much interest. There's almost a feeding frenzy out there as to what solution is the best solution. So that has actually become a challenge rather than an opportunity. Secondly, we are faced with problems of connectivity. Most certainly, many of our places don't have the broadband that is needed, or the Wi-Fi that is needed, or access to the Wi-Fi that is needed to allow for some of these telecommunications to go forward. So that's something to think about. Thirdly, who pays for all of this? Can we get funding? There certainly are funds out there during this crisis for COVID. Can those funds be used to install systems and solutions for telemedicine during this crisis and be maintained beyond the crisis of COVID? And then I also want to bring up a point of what I call misplaced motives. There are many companies out there who are interested in putting out their goods, be they telecommunication goods, being broadband, etc. But their motives sometimes are misplaced in that they are really taking advantage of our patient population, our vulnerable population, perhaps wanting to acquire images on our patients to be used for interesting developments. Chris mentioned artificial intelligence. That is all the rage, where we do need to capture pictures of our patients, but are those pictures being sold to develop artificial intelligence for private companies? And so that's another thing to consider and to be aware of when we're talking about our vulnerable populations. What are their rights, the ethics around that, and privacy around our patients? I also just want to finish up by saying that telemedicine, teledermatology can certainly be used in some innovative ways. We talked, or we've heard about resource limits and various needs in various countries at different seasons. So I think it was an excellent point that Valeska brought up. Yes, sometimes it's steroids that are needed in various camps. Other camps might need anti-scabetics. Other camps might need antifungals. How do we know where to put those resources? So having a system of telemedicine, for example, where we can screen our camps and our patients and understand what the needs are and bring those resources directly and in a timely fashion seems to me to be a great way of using telemedicine. Also for screening, as we talked about, how can we use telemedicine to screen for scabies? How can we use telemedicine to screen for for fungal disease, etc.? And then lastly, I want to talk about using telemedicine for research. And as we are all aware, research in skin disease and research in everything has come to a halt throughout the world, mostly because we want to avoid face-to-face visits, and how do we re-enter into the research arena? And I would just put forth that thinking about using telemedicine in a way to do research and really bring that to the patient, either virtually or using other ways of telemedicine, might be the way into the future. And I can think about home programs. I can think about capturing patients in their homes so that they don't have to have transportation to come to a central area, and to think about how to implement that as we go forward, as we re-enter the world in the what we call the new normal of medical education, research, strategies around implementing drugs, etc. So I think I'll leave it at that. Be interested to go through some of the questions that I see coming up in the chat, and maybe I could take it back to you, Claire, to try to organize those questions.
Yeah, thanks, Toby. Thanks for sort of setting that scene so eloquently and raising the issues that we need to discuss around it. I'm sort of feeling there are kind of a couple of issues around this. There's the use of virtual health. One is the sort of one-to-one relationship which you can achieve with things like WhatsApp and Silo. But that requires a specific connection between individuals. So that's one sort of approach, and obviously we've all been using that. Many of us will be on various WhatsApp groups, and that's a, perfectly great piece of kit for us to use, and it's already out there. But in terms of thinking that something would be more broadly available and potentially manned to provide a teledermatological service ongoing rather than one-to-one, it would need something like you're saying. You'd either have the primary healthcare points within the displaced camps connected to some sort of platform which we might undertake to service, in which case you'd need a platform to do that. Or if you were going as far as you're suggesting, and I like that, of how do we get out to individuals, patients in the community, that's a very, very different look at things. And but I don't think it's a reason not to think about it. So I'm sort of thinking there are kind of different toolboxes we need. There's a review of what we know is out there, the pros and cons of that, but also what would we really like to be able to do, and what can we do rapidly. And you talked about payment, and I know that you've been involved, Toby, in sort of preparing a proposal, so have a kind of rough idea of a ballpark of what a project might cost. But that would be, I think your idea with that was looking at specifically the Cox's Bazar situation rather than anything broader than that. So that's just seeing. Anyone wants to chip in? Rod, is your hand up from before, or is it up again? I think hasn't come.
It was before. It was before.
Yes. Well, very clever to find the hand. I can't find my hand. Anyone got any thoughts that they'd like to speak on? Can I ask a question? Of course you can, Chris.
So just to come back to the discussion around WhatsApp, and I guess in Burma it was Viber, I think, Sue, is that correct? Because that does seem to work quite well on that, as you say, on the one-to-one basis. And I'd just be interested to explore that a bit more detail, because of course, there's more people got access to 3G, 4G than they have to clean water in some places. And I think it's such a, I don't know whether first, maybe I could just ask Sue, because I know she had some experience of dealing with a couple of patients through Viber, and what her view was on that. And then I'll come back to you, Toby.
Thanks, Chris. I started typing that question and then I thought I'll wait and talk about it. So you read my mind. In fact, we did one consultation over Viber of a child with really severe ichthyosis. And she was from the northwestern borders, very mountainous areas of Burma. And we were able to see her and communicate with the families, and we managed to come to a diagnosis and recommended and referred her subsequently to the nearest dermatology center in Burma. So it was a sort of fairly satisfying story. But that we were rather surprised because Viber actually worked pretty well despite them being in a mountainous region of Burma. But I do understand that Viber is not used, everywhere, because I can just see that sort of WhatsApp's probably more prevalent, more widely used. But I just wanted to see actually what Professor Mora think about these platforms to be used as means of consultation, or can you recommend a platform fit for these purposes?
Yeah, thank you. Certainly, we're all using WhatsApp, Viber, FaceTime, etc. I don't know who owns Viber, but I will say about WhatsApp, it is owned by Facebook. And that always brings up questions as to what's Facebook doing with this stuff. There's no evidence to suggest that Facebook is doing anything terrible with the data, etc., but they have access. They have access to those pictures. They have access to patient data in a sense. And so the security of this is always in question. We always feel, especially during a crisis situation, that you use whatever the heck you can use just to deliver patient care. And we certainly all do that. I consider most of my life to be an emergency, and so I have no problems using Viber, WhatsApp, FaceTime, whenever I need to, and my personal cell phone, always. Patient care comes first. But as we go into the future and we are thinking about a stable situation, and a stable situation to also capture images, I think we want to think about how to capture good images, how to capture images so that we can actually make diagnoses. And those are platforms then that are required that can do those things. So I'm talking about high resolution images that are captured and stored and managed in a way that is equitable, but also stored so that people can have access. And so I just want to make a plug for using platforms that collect and retain the data, and then make it available to repositories like the National Library of Medicine, which is a repository of images in the United States. These images live on the public domain. Therefore, whoever wants to do research, be it artificial intelligence research, can use those images to do that. It also helps to build a library in dermatology so that we have a place to put good images and build a library for patients of various skin colors and ethnicities and races, etc. As you know, many of the stored images that are around are basically for white patients who present with melanomas and basal cells. There's a lot more to dermatology than that. And so there's a real push and a real need to have those images available to all of us who do work and research.
Aisha's got her hand up. Aisha Sethi, would you like to come in?
Yes, hi everyone. Hi Claire. And I'm sorry my video isn't on. My house is a bit of a mess. I have a house showing in the middle of COVID. Put our house on the market, so I don't want to show that to everyone. So I think it's such a great thing we're discussing telemedicine finally, and like Toby said, it's become like the thing now, and we actually here at Yale have all gone to telemedicine, and all of us well versed in it, we're suddenly in demand for, you know, how do we do this? So I wanted to mention what Valeska mentioned and a few other people. And from my experience, having worked with WhatsApp, Viber, various platforms in various places, I just found that this is an issue and a time where you have to balance availability, ease of use with security issues. And I used WhatsApp and Viber actually in a few different scenarios. Viber and WhatsApp came about at the same time, and somehow, I guess, I don't know, WhatsApp had more money or funding, became the more popular app, but somebody mentioned Viber and it's equally as good. So there's a few ways I've used WhatsApp, and I can again write this all down and share it with everyone and Claire. WhatsApp is widely available. Patients have it. There's different physician groups actually on WhatsApp from various countries that use store and forward and can take pictures and can be guided how to take pictures. So that's just, I wanted to say in favor of those till we have the time and the funding to develop something more universal. Just wanted to share my experience with those.
And I'm grateful to Tori. Tori Williams has popped up a reminder of her 2 excellent articles that she's written on this subject. Tori, do you want to kind of, I don't know whether you can summarize them in 3 minutes or less?
Probably not in 3 minutes, but I mean, it's really challenging to find something that's universally available to the people that you need to get access to. And I mean, in trying lots of different platforms, the bandwidth is what just becomes the biggest barrier. And the fact that most of the providers you need to get in touch with only have a phone that's usually a basic Android, and either WhatsApp, Viber, Facebook Messenger. I mean, these are the things that they have. And I feel like WhatsApp has been the most accessible and most secure. And it's so versatile in the fact that you can create those different chat groups and you can create these permanent links with different providers. And so over time, you can reconnect with people to get follow-up. And I find that really, really valuable.
Thank you. Thank you for that. So we've had a real range of contributions, and also the kind of pros and cons are appearing in the chat. So that's been very helpful, and particularly thanks to Tori for sharing the links to her 2 articles which have reviewed that. So I guess, like quite often happens in these situations, Toby, we end up with more questions than answers, but I just wondered whether you had a sense of where we might go next and what would be the next step in trying to progress a response, an action, an implementable plan for regarding immediate approaches.
Thank you, Claire. You know, in just thinking about this in the recent weeks, I think there is a real need for a community of us to get together to try to figure out what platforms, funding opportunities, ways forward, what are the things, the safeguards that we need, what are the specifications for gathering pictures, where to put them, how to store these things. This is an opportunity in which we can actually develop, I think as Tori said in a sense, how do we best develop a strategy around this? And I would just make a push for us to somehow gather with one another again. In one way, I don't know if it's email, maybe through telecommunication as we're using now, to really pound out some of these issues and try to figure this out. And again, bring up opportunities for funding that might be out there that we could all have access to as well.
Thank you. And I suppose going back to your comment, let's not waste a crisis, or you said it much more eloquently than that, but there is the pounding out and trying to move forward and look for funding, but there's also just cracking on with it while we can and doing what we have been doing. And I can see from the list of approaches, obviously there's a concern about the security, about WhatsApp. We've obviously, you've made that point, and Dominic's also brought that up a couple of times. So there are concerns, but there's also the opportunity that this pandemic is providing us with is an acceptance that we would be doing it. Any support that we can give people diagnostically might be worth just accepting those risks. So I'm aware we're just coming to the end of our time, and we were trying to wrap it up by 1:15. I think what we've heard is an amazing range of headline themes from our first 3 speakers, and then a wonderful set of examples of challenges and experiences in the field, and to be also contributed by a real breadth of expertise from our participating audience, who've also contributed wonderfully in the chat with various links and so forth. And I can see that we're sort of developing, what I'm sort of seeing coming out of this is a need to really clarify what we need. What do we need in our toolbox? And I think that's what I'm going to try and summarize after we come off this call. And we'll circulate the report to you. But I think in our toolbox, we might be thinking in terms of those various chapters that we had, or we were thinking about doing for our breakout session, had we been a face-to-face meeting in Malta, where we were planning on being this week. But also prioritizing around, I'm hearing the things that were obviously most high on our mind is telemedical support, in order to be able to continue to assist when we're not going to be able to be physically present, as a priority, and also developing recommendations for what drugs should be available and how we might support diagnostics. We could chat on for a long time, I know, but I think we must draw this to a conclusion to allow those at various ends of the day to do whatever they need to do. And I look forward to reconnecting with you all with for ideas for our special edition journal issue, and also to progress this work. And also would love to have ideas from you. Do email me of who we should include in our membership of this IFD Migrant Health Working Group for Dermatology. So I think obviously we have dermatologists involved, but I wonder if our non-dermatological colleagues on the call would be interested in staying connected with us, and recommend any other people, any other interested parties and partnerships we should be thinking about. So if there are no little hands popping up or immediate concerns, I would like to just thank all of our speakers, the chairs, the ILDS Secretariat for their contributions, for your generosity in all the sharing that you've done via chat, for your willingness to participate with this programme and to keep this community going, growing and moving forward. And I look forward to welcoming you to a face-to-face meeting, hopefully Valeska in Malta, within the next 12 months if we possibly can, in order to be able to really escalate this process. But prior to that, I'm confident that we are going to get some deliverables achieved. So, and finally, I'd like to pay a particular thanks to David Felker, who has been supporting the Zoom technology. I think it's been faultless. You are brilliant. I think he's driving around in his car so that he can do this, keeping him focused and able to concentrate. So thanks so much, Dave. And have a wonderful rest of the day, night, or whatever you're doing, and look forward to staying in touch. So bye.
Bye, thank you.
Bye, everyone. Thanks again.
Bye.
Bye.
Bye. Bye. Thank you so much.